This lecture will be on the MN big S little s blood group system, brought to you by the one and only Kasey Doney MLTA CPCM and Joshua Tay. These are the objectives for the MNS blood group system unit. Clinical significance of alloantibodies, immunogenicity of antigen, antibody specificity, antigenic dosage, number and location of sites on the cell, modes of inheritance, incidence, antigen development, known biological function of antigen, correlation with disease states, and reactivity after enzyme treatment. We will also compare and contrast the glycophorins, as well as describe the M, N, big S, little s, U, U variant, and ENA antigens and their associated antibodies, as well as go into further depth on the anti-M antibody as well as the anti-NF antibody. In 1927, Lonsteiner and Levine reported new anti-M and anti-N antibodies following rabbit sera studies where they injected rabbits with human red cells. Later, in 1947, resulting from the development of the anti-human globulin test, or the Coombs test, Walsh and Montgomery discovered the big S antigen, which was genetically linked to the M and N antigens. Then, in 1951, big S's antithetical partner, little s, was discovered. Another high-prevalence antigen in this system, U, was discovered in 1953. It was linked to the MNS system due to big S negative, little s negative individuals usually testing as U negative as well. The reason why will become clear when we go over glycophorin B in a couple of slides. The MNS system was designated with ISBT code 002, just after the ABO system ISBT code 001. The antigens we will discuss are M, N, big S, little s, and U. There are over 40 other high and low prevalence antigens in the MNS blood group system. However, their associated antibodies are not commonly seen in the blood bank. Glycophorin A is a sialic acid-rich glycoprotein. Glycophorin A contains the M and N antigens when they are genetically inherited and phenotypically present. These antigens are well developed at birth. The M and N antigens are located on the distal end of glycophorin A, which is significantly longer than glycophorin B. These two factors allow M and N to be easily destroyed by routine enzymes like bromelain, papain, physin, and others. M and N reactivity can also be destroyed by treating red cells with ZZAP, a combination of DTT and either papain or physin. However, DTT nor AET, or 2-aminoethyl isothiauronium bromide, are capable of destroying the M and N antigens alone. This diagram highlights the differences between the M and N antigens. The key difference between antigens M and N are the first and fifth amino acids of glycophorin A. In the M antigen, the first amino acid is serine, and the fifth is glycine. In the N antigen, the first amino acid is leucine, and the fifth is glutamic acid, which is also known as glutamate. Glycophorin A is a long glycoprotein, and the first and fifth amino acids that comprise the M and N antigens are located at the very end, away from the cell membrane. Therefore, the M and N antigens are easily destroyed by routine enzymes. This is a different case for glycophorin B and the big S, little s, and U antigens, which are coming up next. As a way to remember the amino acids that differentiate the M and N antigens, I've developed mnemonics for you that will hopefully help. For the M antigen, 15 mighty spicy garlics, 15 for amino acids 1 and 5, M for the M antigen, S for serine in the first position, and G for glycine in the fifth position. So say it with me, guys. 15 mighty spicy garlics. Similarly, for the N antigen, 15 Naruto's love Gaara. Little anime reference for you. Go ahead and say it with me. 15 Naruto's love Gaara. Glycophorin B contains the big S, little s, and U antigens, of course, when genetically inherited and phenotypically present. These antigens, just like the M and N antigens on glycophorin A, are well developed at birth. Glycophorin B is short, and the big S, little s, and U antigens are located farther down the glycophorin, close to the cell membrane. So routine enzymes have trouble destroying these antigens and their reactivity, which can mask other underlying alloantibodies. Longer incubation can eventually destroy the big S and little s antigens, which are farther from the red cell membrane. However, the U antigen is so close to the membrane, it can sometimes be impossible to destroy with routine enzymes. U antigen stands for universal antigen due to its high prevalence in humans. It is only documented to be missing in approximately 1% of African Americans. The U antigen is present almost ubiquitously in humans regardless of big S or little s phenotype. For individuals that are U negative, they are usually big S negative and little s negative as well, due to a complete deletion of the glycophorin B gene, or GYPB. This diagram shows the differences between the big S and little s antigens, as well as the location of the U antigen on glycophorin B. The key difference between big and little s is the 29th amino acid. In the big S antigen, the 29th amino acid is methionine. In little s, the 29th amino acid is threonine. A mnemonic to memorize the big S amino acid is 29 birth sign mythologies. This is for amino acid 29, then big S and methionine. Try and say it with me. 29 birth sign mythologies. For little s, 29 super small thermometers. And say it out loud one time. 29 super small thermometers. Small s and thermometers for threonine on that one. Sorry that these have been a little bit lame, but I hope that they help you. Stepping aside from the required material for the exam, the tops of both glycophorin Bs, shown in brackets up here, share the same amino acid sequence as the first 26 amino acids in the N antigen located on glycophorin A. In effect, they mimic the N antigen. This is termed N quotes activity, and it is important for one kind of rare anti-N antibody that can develop in individuals that are both N negative and lack glycophorin B entirely. Again, glycophorin B gene deletion is the most common cause of this. This potent form of anti-N can direct against both the N antigen and glycophorin B, causing hemolytic transfusion reactions. Now just a quick review of what we've learned. A patient with glycophorin A with leucine at amino acid position 1 and glutamic acid at amino acid position 5 is positive for which antigen? Good job, it's N. Remember that for M, it is also located on glycophorin A, but the first amino acid is serine and the fifth amino acid is glycine. Then for the big S, little s, and U antigens, those are located on glycophorin B. Great job. Which antigen is difficult to destroy with routine enzymes? Good job. It is the U antigen. You could also answer with big S and little s, but those are just slightly more difficult to destroy. They still get destroyed in the end. Next, what is the most common cause for U negative phenotype? Nice one. It is the GYPB gene deletion. This is, again, only found in about 1% or less of African Americans. Thank you so much for your time so far. This is the last slide for me, and I'll turn it over to Kasey. But this table shows the prevalence of MNS phenotypes, and you can use it to reference in the future. And it gives insight into how difficult it is to find compatible blood units in case of unexpected alloantibodies. You'll also notice at the bottom the big S negative, small s negative, U negative line shows that only 1% or less of the African American population is this phenotype.
Hey everybody, this is Kasey, and I'm going to start by telling you about the MN antigens. So these antigens are an antithetical pair. They are codominant. They are well developed at birth, and due to location, they're easily destroyed by routine enzymes. And what that is referring to is what Josh went over, with the glycophorin that they're on. So I'm going to give you a second and see if you can remember which glycophorin M and N are on. Yeah, wow, I can't believe you remember that. You are a genius. Yes, it is glycophorin A. And because of that, they're on the outside of that glycophorin and are easily cut out by enzymes. And something else that is important to know about M&N is that they demonstrate dosage. So when you're doing something such as an antibody cross-out, you want to make sure to choose a cell that is M positive and N negative. So you've already encountered something like this, and you'll probably see in other presentations. But specifically for this one, anti-M, you may want to use cells that are M positive and N negative, homozygous, and vice versa for anti-N. Okay, so to start talking more about anti-M and anti-N, anti-M is often naturally occurring under 37 degrees Celsius, so it's non-RBC immune. It doesn't require transfusion or pregnancy to produce these antibodies. It's 50 to 80% IgG or contain IgG component, and that's really important to keep track of when you are considering whether it reacts at body temp or at room temp. Anti-M does not bind complement, which is really important in why it doesn't have super bad hemolytic reactions. As you can see, it rarely causes HDFN or HTR, and that's partially because of this complement binding that doesn't occur. Anti-N is more common in children than adults, and particularly common in infections and also burns. Anti-M, when seen in the lab, can be very weak and need extra enhancement. Things that you can do include increase serum to cell ratio, increasing incubation time, slightly acidifying the plasma to about a pH of 6.5, and exposing the cells to glucose solution can change how the anti-M reacts with them, or whether it reacts with them or not. And as always, the reactions are only clinically significant if they are reactive at 37 degrees, which is body temp. For anti-N, it's pretty similar to anti-M. It's less common, but it's also IgM or IgG. It's also non-RBC immune. It also does not bind complement. It has also rarely been implicated in serious reactions, and in this case, it's only been implicated in mild HDFN. More specifically about N is anti-NF, which is seen in dialysis patients. So when someone's on dialysis, the machines, at least for these individuals, the machines are sterilized with formaldehyde. And whether they have M positive, negative, N positive, negative, the formaldehyde can change their glycophorins and make them appear to the body as foreign, and they will form these anti-Ns against them, regardless of whether they have N antigens or not in their blood. This is something that's not clinically significant because it's not reactive at 37 degrees, so it's not something that should be worrisome, but it's just something that might show up. The other thing to note about this is that after they stop dialysis, it will often go away with time, or at least decrease with time. Okay, the other antithetical pair in this unit is big S and little s. They are also codominant. They are well developed at birth, and they are less accessible than NM, but they are still destroyed by routine enzymes except trypsin. So here, I want you to consider which glycophorin big S and little s are on. Good job, glycophorin B. Wow, you guys are really getting it. Yeah, so because of that, they're not on the outer edge like that glycophorin A allows the M and N to be. So it's harder for the enzymes to get to them, but they can still be destroyed by them. Anti-big S and anti-little s also is involved in dosage, like big M and N. And unlike M and N, these ones are mostly IgG and reactive at 37 degrees Celsius. Some can express optimal reactivity between 10 degrees Celsius and 22 degrees Celsius with saline IAT. Immediate spin can help in identification. That's something that they mentioned in the textbook, that if this is a suspected antibody and there needs to be a clear distinction between reactions, that's something that can help. The really, really important thing to remember about anti-big S and anti-little s is that unlike M and N, they may bind complement, which can lead to severe hemolytic transfusion reactions with hemoglobinuria or HDFN. So these reactions are going to be typically worse than reactions with anti-M or anti-N, even though they're a little less common. Specifically, that anti-little s. Little s is a super common antigen, and anti-little s is going to be hard to find blood for because it's super common. So U antigen is the universal antigen. I think Josh talked about this a bit. It's located on that GPB, that glycophorin B near the membrane. It's resistant to enzymes. It's RBC immune. So for this one, you're going to need a transfusion or pregnancy to sensitize to that antibody and produce that antibody. And it's very, very high prevalence on red blood cells of all individuals except for about 1% of African Americans. And it's usually caused by partial or complete deletion of the GYPB gene, which is what causes the formation of that glycophorin B. So it's really rare, and it comes from a deletion is what causes this. Anti-U is going to be IgG and can cause HDFN and HTR. So generally, I think this one's considered a little more bad per se than M and N, but like M and N, it doesn't bind complement, so you don't have to worry about those super severe reactions that you can get with big S and little s. U-Ver phenotype is a phenotype that comes from an apparent lack of UNEG. So the altered glycophorin B lacks big S and little s, which makes it seem that UNEG is not present, because if you remember, any glycophorin B that has big S or little s on it is going to be positive for that U antigen. So when both big S and little s are gone, it appears to be UNEG. However, it reacts with anti-U. So these apparent UNEG cells may appear to agglutinate weakly by adsorption and elution. And this is something to consider important because when people are getting blood transfusions, they may have reactions with this U-Ver if they are UNEG with an anti-U. Okay, ENA, the EN is for envelope. It's a high prevalence antigen. Much like the U antigen, most ENA-neg individuals can or will develop this anti-ENA. There's multiple causes of this phenotype, which leads to the development of this antibody. These include inheritance of variant alleles that can be homozygous or heterozygous inheritance of multiple variant alleles. They can also include homozygous glycophorin A gene deletion. So with these individuals, you'll often see that they are M-neg, N-neg, and the reason for that is that they are missing that gene. So when we talk about anti-ENA, it's an umbrella term for all the antibodies directed against various portions of glycophorin A. So it's regardless of M or N phenotype, because as we mentioned, it doesn't necessarily have to be missing that glycophorin A, but it often is. And these are important to consider because they have been seen in severe hemolytic transfusion reactions and HDFN. Here is a chart to kind of review everything that we've just gone over. It shows antigen frequency, which I think is important to consider. Little s is more common than big S, and that's something that's important to remember, especially if you need to find little s blood. It's going to be difficult, or little s negative blood, it's going to be difficult. And that U is really, really prevalent, so keep that in mind. Other things to note on here is all of it, but specifically complement binding. Remember, it's that big S and that little s that complement bind. IgG class or IG class, big S and little s can be IgG or IgM, but they're really usually IgG, which is why I put that. And then remember which antigens can lead to severe reactions, or antibodies can lead to severe reactions. And here are references. Hopefully you enjoyed, and I hope you learned something. Thank you for watching.